Everyone, thanks for listening to my presentations. Today I'm talking about superior Vena Cava syndrome. Have you heard about that before? If not, let's go. Normally, before we get into the trouble of superior Vena Cava syndrome, blood will return to the heart where the inferior Vena Cava and the superior Vena Cava, that is, from the lower parts of the body and upper parts of the body respectively. In an abnormal situation like this very syndrome, there would be an obstruction to the flow and emptying of the superior vena cava into the right atrium. This could have been impeded by either metastasis or direct compression of the vein by the neighbouring tumors. Pathogenesis. Superior vena cava is obstructed either by malignancy, causing pressure effects on the superior vena cava, or enlarged mediastinal lymph nodes, or direct invasion by tumor, or sometimes by metastasis. Once there is obstruction of the superior vena cava, collateral veins will be needed for the return of blood to the right atrium. And at that level, we'll need azygous veins, internal mammary, lateral thoracic, paraspinous, and esophageal venous systems. Like possible clinical features, there will be dilation for weeks, and there will be elevated central venous pressure. That will in turn lead to the following: swelling of the neck and face, chest pain, shortness of breath, dyspnea, headfulness walls with lying or bending forward, and swelling, stridor, or cough. Still, on possible symptoms, there could be hoarseness of voice, difficulty swallowing, that is dysphagia, respiratory distress, headache, thrombosis can develop, cyanosis, and facial pretoria. When there is cerebral edema, we're dealing with headache, confusion, visual disturbances, auditory disturbances, and of course brainstem herniation leading to death. How do we grade superior vena cava syndrome? Grade 0 has no symptom, that is asymptomatic, and that will be diagnosed only radiographically. Grade 1. This is also known as the mild state. It's associated with vascular distortion or distension in the neck or head region, also associated with cyanosis or pretoria. In grade 2, this is known as a moderate state, with the features of grade 1 and functional impairment. Also, there's likelihood of mild dysphagia, cough, mild or moderate impairment of the head and jaw, or the eyelid movements. And why that? Because of the ocular edema. In other words, there will be ocular edema in grade 2, and that is still a moderate state. In grade 3, tag this as severe state. Here, we'll be dealing with cerebral edema, headache with dizziness, laryngeal edema with possible cardiac syncope when bending forward. In grade 4, this is tagged as life-threatening state with confusion, obtundation, stridor, syncope, hypotension, renal impairment, all from cerebral edema, laryngeal edema, and decreased cardiac output. In grade 5, This is tagged as fetal state. In other words, death. How do we make diagnosis of superior vena cava syndrome? Thorough history, follow all the clinical features listed before now, grade the severity as described now in the last few minutes, venography catheter-based procedures, CT venography, duplex ultrasound, or magnetic resonance imaging. Still on diagnosis, the gold standard for the diagnosis of superior vena cava syndrome is the superior vena cavogram. This is a conventional catheter-based central venography. Histology could be done in cases where you are suspecting or you are sure of malignancy. In that case, you can have sputum cytology, pleural fluid cytology, CT-guided biopsy of pleural lymph node, bone marrow biopsies, bronchoscopy, mediastinoscopy, and thoracoscopy. What are the possible differential diagnoses here? Indwelling intravascular devices, post-radiation fibrosis, fibrosing mediastinitis, cardiosis, and agenesis of superior vena cava. Still on differential diagnosis, it could be adjacent tumor directly comprising the superior vena cava, or might be dealing with indwelling catheter presence, or tuberculosis, actinomycosis, aspergillosis, blastomycosis, or filariasis. Treatment of superior vena cava syndrome should start with the treatment of the responsible cancer, and that could include radiation therapy, stenting to open the obstructed superior vena cava, and of course determine the severity of symptoms, because that will guide the treatment. And we have to stage the superior vena cava itself, like I've just gone through, and also stage the tumor that is causing the problem. But it will be better to stage the tumor first, so that we'll know whether surgery will be helpful or not, or we'll not just resign to fate and continue with chemotherapy and other palliative measures. But in emergency situations, things will be different. And how do we know whether this is emergency or not? It is emergency when there is obstructed airway, when there is severe laryngeal edema, when we are dealing with cerebral edema, or the patient is in coma. Then the pattern will change to emergency treatment. Okay, the determination has been made that this is an emergency. And we have to start with A, that is the airway. Is the airway patent? Any foreign body, any secretions, we have to sanction or remove as it may be appropriate. B, for breathing, what is the O2 side? If it's low, we give oxygen. What is the respiratory rate? Any peripheral or central cyanosis? Can we feel the trachea positioning, any deviation? Any obvious chest deformity? Is the abdomen moving with respiration? You can percuss right now for any dullness or hyperresonance. Have you auscultated? Please kindly do for breath sounds. Then CC is all about circulatory system. At this point, we'll ask for vital signs. What is the blood pressure all about right now? Is it hypotension or not? What is the heart rate? Then we'll auscultate for the heart sounds, any murmur, peaked, and of course, features of dehydration, skin turgor, or sunken eyes. And after that, we'll have to send consult because we need a venous recanalization of the superior vena cava with stents. We can call for anticoagulant if there's thrombosis, or we use thrombolytic agent, but we have to rule out contraindications to thrombolytic agent. You can get all these if you check my channel for presentation on pulmonary embolism, venous thromboembolism, and of course myocardial infarction. Note: local irritation or thrombosis in the chest region or neck or upper extremity will prevent us from using that affected limb or limbs. Okay, still in emergency room, we can make use of glucocorticoids if we're battling with radiation therapy or the malignancy is steroid responsive. We can use diuretics as may be required. It is good to hydrate well, but we should reduce overhydration. That is why we're going to have physical examination done and also auscultate the base of the lungs to know whether we're dealing with pulmonary edema or not. Chemotherapy is welcome as necessary, and of course, timely intervention after accurate diagnosis of superior vena cava syndrome will help a lot. Thanks for listening. I appreciate. Please remember to share. Remember to subscribe. Thank you.